To have you here talking about clinical interoperability with three wonderful panelists, an East Coaster, a West Coaster, and someone from the middle of the country, and in three different roles. We're very excited that it worked out this way. So let's welcome Judy Raposa from Pediatric Associates of Fall River in Massachusetts. Dr. Charlene Matthew from East Portland Pediatric Clinic in Oregon. And Kim Raley from Westside Pediatrics in Cincinnati, Ohio. Okay, great, I got it right. My name is Sarah Gleish. I am an educational content creator with PCC. I've been here for 2+5 years. And I work with the Clinical Data Exchange team. I am joined by my co-host, Brian LeClaire. He's doing all the video and audio production for this UC, so let's give him a hand because that's a huge job. Clinical interoperability. It is alphabet soup. I work in it every day. It is really hard to understand the letters, what they mean, which one is a standard, which one is an organization you're working with, what data are you submitting to them. But it's so helpful, it can be so helpful for your practice to get connections to the vendors, to the departments in your state that need information from you or that you could benefit from sending information to. And moving from a paper process or a process where you're going to a portal on a website, remembering that password, they change it every 3 months. You have to make up a new password. You don't remember it anymore. The staff member who knew that process leaves your practice. By engaging with PCC to build connections to these vendors, you kind of take away some of that pain and you retain the benefit of that connection. So here to talk about three very different use cases in their practices are our panelists. I want to give Brian a chance to say something if he has anything he wants to add before we jump into our first question.
I can't up that at all.
Okay, he can't up that at all. I'm doing good so far. So my first question for each of you, I'll ask you if you want to say a little bit more about your practice or your role. So I'll start with Judy. You can tell us a bit more about yourself, and also you're going to be talking to us about a lab connection.
Yes.
What was the moment that you realized there was a better way or that there was a problem that needed to be solved?
Okay, we're a practice of 6 pediatricians and 3 nurse practitioners. We have a staff of about 50, so it's a busy place. We're open every day. We're open evenings, so it can get crazy at times. And the last couple of years, it's been really challenging because our lab staff left at the same time. We had 2 people working in our lab, and one of the ladies had worked with us for 10 years, and she hired her cousin, and both her and her cousin left at the same time. So we went through a big transition period, and Brian knows some of it because he was part of when we were going over to Relay Med, and they left with everything in their head. So it was like we tried to put somebody from within. We hired outside. Well, in the last 2 years, I felt like I was calling myself the Terminator because I fired so many people that I have, and I've been there for 30 years. So originally, when we moved to our practice, we had Orchard, and PCC played a big part in us getting on Orchard, but we never, thank God for PCC, because we never had the support from Orchard. So after everything going on with COVID, we decided that we wanted to put our machines on Orchard, and Orchard shot me a price of $50,000 to do this. At that time, I reached out to Brian. I said, oh my God, they want $50,000 to put 4 Abbott molecular straps. I wanted to put my Cepheid on and my urinalysis analyzer, and they wanted $50,000. I said, I can't do this, blah, blah. So we worked on it, and we had to hire a lab consultant who was helpful. And she mentioned Relay Med. And she says, but you can't go with Relay Med because PCC doesn't interface with them. I said, but you don't know PCC. I said, I'm going to make a phone call. And Brian was involved in it, and it's the best thing we ever did because everything drops right in.
That is amazing. Thank you for sharing that. We're going to get deeper into that in just a minute.
Okay.
I'd love for you to pass the mic to Dr. Matthew. Dr. Matthew, can you tell us a little bit about yourself, your practice, and when you realized there might be a better way to solve the problem that you were facing?
So I'm in a small practice of 4 to 5 pediatricians. We're down to 4 right now, but hiring. But we are part of a larger group called the Children's Health Alliance in the Portland area, Salem, Vancouver, of 27 independent practices. This alliance started in 1998 and has been very forward-thinking. So we started doing clinically integrated work so that we can contract together back then. We started with pulling charts, tracking immunizations, putting it into a spreadsheet, sending it to the CHA, and they would compile all of our immunizations and where we're at. Then we added asthma management, but all of this was done on paper and spreadsheets. They put together an asthma registry. But as time moved on, value-based contracts started happening, insurers were requiring more and more different reports. We realized we really needed a better method. And by that time, pretty much everybody was on EHRs, but on multiple different EHRs. And that's when, as the CHA, we decided we needed to onboard a population management tool. And then we had to have everybody's EHRs feed into that. So that, I think, was 2013 when we started that.
Awesome. So we'll move on to Kim. So Kim, can you tell us a little bit more about yourself, and also when did you first of all figure out that there was something that our team could solve for you, and how you got there?
So I'm the nurse manager at Westside Pediatrics in Cincinnati. We have 2 offices, 10 providers, so 7 doctors and 3 nurse practitioners. We have about 8,000 patients. So I first figured out, well, I didn't figure it out, you figured it out, but I first asked the question, could this happen? Last year at the users conference, I saw a blurb. They had a bunch of, it was like a word bubble, and it said, you can report your lead reporting. And I was like, we can report lead directly to the state, and I don't have to input this manually all by myself anymore. So I contacted PCC, and I was like, is this possible? And then I got in touch with Brian, and he worked all the magic and got it all figured out. And so now it all just automatically goes. I don't have to manually report it. I used to have to enter it into, well, probably lots of people do this, but you had to enter it in the lead care system, and then you had to download it to the FileZilla, and then you had to send the file through the FileZilla to the state. And that would probably take me about an hour every week. We have anywhere from 10 to 25 lead results each week. But now it just goes automatically, so I still run the report, but to make sure they all went. But only one time did one not go since we've started.
Very nice. I do want to mention, in my head, I just did the math, and that was kind of wild to me. I love automating things. I've always loved automating things as a nerd, as someone who loves computers. So that saves you 52 hours a year, theoretically, which is amazing. That's 52 hours that you can be doing other more important things in your role, right? So I am going to switch over, as long as Sarah says it's okay. Okay, we're good. I'm still in AV land. I'm still thinking about video. I hope I look good over there. Yeah. Yes. So I'm going to move back to Judy, and I did want to kind of lead into this. I think my personal opinion, and I'm curious if we can see by hands. Did you folks know that we will work with you to get point of care testing devices integrated with your EHR? So there are some limitations. Judy and the Pediatric Associates of Fall River have definitely taken the most advantage of this. So I'm curious to hear what Judy's going to say to some of this. So let's see. You've already described some of the questions that we had laid out. There was a time before you even had orchard trellis, correct?
Actually, as soon as we went over to EHR, we kind of did it hand in hand because we knew that the lab had to, but it wasn't an easy process at all. I mean, last integration was so much better. I mean, it was done right. I think Relay Med was eager, and I think PCC worked well with them. They did anything. I really just, when I called Brian, I was just doing a shot in the dark. I'm saying, do you think they're going to want to go? They're going to tell us to stay with Orchard. I mean, but it was, no, fine. Don't pay the $50,000. Let's work out something. And with Relay Med, we pay, I want to say, it's such a savings because I think it's costing me like $180 a month because it's a per provider payment that you pay. And their support is, of course, nobody's like PCC, but they've come close. I mean, they check on us every week to make sure they're watching things. So another brother's watching us, like not only PCC, but I think, I don't know on Brian's end, because I know he did some stuff with them alone, but I think they were pretty easy to work, and they're eager.
Yeah. So if any of you have like regular electronic lab interfaces, so these are results-only interfaces like from Quest or LabCorp, this works a lot like that. It's we have multiple partners. The main one that we work with right now is called Relay Med, which is what Judy is mentioning. And Relay Med will come into your office, connect all of your machines that you have for point of care testing, and then you'll receive the results from that into your EHR. There are some limitations. Oh, good.
I actually, they talked me through. They sent me the the equipment. It was simple, like plug it. And they stood on the phone with me. They said, okay, do this, do that. Let me see if I can see it. And it was no big deal. Yes?
I'm thinking this would be really awesome for point-of-care cholesterol testing.
We use it for cholesterol.
I'm not sure if you actually have to then attach it to a chart, is it really saving any money from clicking positive or negative for a rapid strep?
You
go ahead, because you
So-
can explain it to how
Yeah,
it
so the
dumps
question
in.
was, can we use it for, XY machine, and does it really, for like a Boolean test result, like a yes or no test entry, does that actually save any time? My opinion is that it depends on your practice. It depends on your workflow. For Judy's practice, it works out pretty well. There are a few practices that have approached us about Relay Med integrations before that have said, okay, if it's only unidirectional, then it doesn't really work out in a financial sense for us. That said, we're really interested. We talked on Wednesday morning session about we'll soon have bidirectional lab results and lab ordering and results. Quest is the first that's coming with that, and then we're really, really interested in some of these point of care integration providers like Relay Med. So that's when I think the answer becomes an easy yes. But of course, it's
And then there's
depending
no
on-
error really, because you're not getting the wrong values in there. It saves time. Well, for a short amount of time, we didn't have the machines hooked up, and my lab people were going crazy. They said, oh my God, are we going to get something? We have to get something in here. It's taken so much of our time. We have one person just doing this. We have a busy lab. We have Cepheid we do COVID testing, our RSV. We do GC and chlamydias on it. So we have a lot of lab equipment. So for them, for us, it was worth every bit of it. We save time.
And what's the cost structure again?
I think it's $45 per physician per month.
Okay, but can you just explain, it doesn't matter what the machine, like it does integrate with Abbott or it does not integrate with Abbott?
Yeah, it does integrate with Abbott. Yeah, our Abbott is set up and the results go in.
So you have both Cepheid and Abbott.
We have Cepheid, we have Abbott, we have a CBC analyzer. What's the name of our CBC analyzer? I can't remember.
Per provider, it doesn't matter how many different tests you have, it's just
No.
how many docs you have within.
That's it. It's kind of like when you have Doxy Me, you're paying per provider or something like that, same kind of thing.
What about if you have one doctor working in 2 offices, do they charge you per location?
I only have one location, so I don't think so. I don't, well, I don't know.
It looks like there's small size, there's medium size, and enterprise. Medium allows for multiple locations. So it probably depends on what you're talking about.
We're gonna be harassing you on Monday.
You can absolutely harass me on Monday.
if any-
I know what practice you're from and have been trying to get in touch.
Yeah, and you can certainly give me a call, and if anybody wanted to come and visit and see how it works, you're welcome to go. It does, it works great.
So,
Massachusetts,
Yeah, you're far. Where in Masco?
Fall River.
so for the folks online, we'll try to do our best to remember to repeat questions. There was just a lot of discussion about the pricing structure of RelayMed and what they support as a company. The answer was pretty much everything. Their full device list is on their website, and if they don't have a device that you're using, they usually can try to integrate with it as well from their end. I was told though that we do have some online questions.
Question 1 is, does RelayMed do only office machines, or they also do hospital labs?
So
I'm not sure.
the question was, does RelayMed only do office machines, or do they also do hospital labs? I believe they are
It's just
only a
office.
point of care integration company. So only the machines that are in your office.
I believe that
Yeah.
you're right.
The next question is, they want some examples of point-of-care tests of the devices in question, which might be beyond the scope of this.
So maybe you can try a shot at it. I think you gave a few, but so examples of point of care tests and
The actual machines themselves.
the actual
Oh,
machines.
okay,
Oh, the
so-
Abbott ID Now is a great one.
We have the Abbott ID now. We have 4 of them in the office. We have 3 in our lab, and we have 1 in our nurses' station, because on the weekends, the nurses do the molecular strips, and it's so easy. It's simple. I run them. I could run them. I've done them. It's really, really easy. We have the Cepheid, which does the flu, the RSV, the GC and chlamydia. We have a cholesterol analyzer, and we also have a urinalysis on it. And we have a CBC machine, and it's not a Coulter. That used to be our machine. I'm trying to think of the name of it, and I can't remember the name, sorry. But it's a brand new CBC machine that we have. So all those machines are on. The doctors love it because they were going crazy with the results go in so much quicker than Orchard did. I mean, by the time the test is done, the doctor's seeing the patient, they have the results. It's quick, really quick. They don't do that, I don't believe, no. I'm not sure, though. They might. I didn't ask. Well, I might have to ask that.
All right, we have a question right here in the audience.
Oh,
Oh, also asking about hearing test results. Okay.
And the last one is, when is bidirectional with LabCorp anticipated?
As soon as bidirectional with LabCorp is anticipated, as soon as we're finished with bidirectional with Quest. Our biggest holdup on lab results or lab ordering is specifically just we're trying to make sure that we get the user interface and the user experience really right as far as in PCC EHR. So we're very actively working on it.
Thank you so much. So another hand for Judy. This may not be the last time we hear from her, but we're going to pass things on to Dr. Matthew. I think you've blown a few minds here today about what's possible.
it was really easy.
Just call Brian, but wait till Monday. He would really appreciate that. So Dr. Matthew, you've already told us a little bit about the Children's Health Alliance. You mentioned that you had selected a population health vendor. Can you tell us about that process, what it was like, and what you were looking for in that process?
What were we looking for? Well, of course, nobody has anything pediatric focused. No surprise there. Initially, the vendor that we went with was called Wellcentive. And at the time, so a little over 10 years ago, they were wanting to beef up their tool with pediatric measures. And They actually gave us quite a discount in exchange for our expertise in, like, here are the measures that matter for pediatrics, and it's very different than things that you should be tracking for adults. And then they were like bought out by somebody, which was bought out by somebody, which was bought out by somebody, and then they stopped doing that, what they were doing, and now we have a new vendor called Wellcentive. But we really are looking for a way that we can feed in clinical data, but also, so we use it for clinical measures, but also to create work lists and registries and document some care management things that, so these are all these measures that we as a group, we compile together, we share on a regular basis with each other, and where was I going with that? Anyway, so a way to get the data in and get work lists out, and then also be able to report out to a number of different entities.
And what do you do with that data? How is it actually used?
Oh my gosh, it's the best thing ever. Best thing ever. It's expensive, and like every 2 years we have a big conversation about, do we need this? Can we do all of this just each with our own individual EHRs? In the beginning, we were the only group on PCC. Over time, it's interesting. It's really like the field has narrowed. So now there are, I think, 5 now groups, 5 of us on PCC. There's Epic, and there's a couple other EHRs. So we get quarterly reports that compare everybody's data on immunizations, child check rates, what else? Asthma care, care management care, population risk tiering, depression follow-up, development, depression screening and follow-up, substance use screening and follow-up, development. So a lot of strong clinical data. So when we're sharing it with our competitors, that we all work together. So there's a little bit of incentive when you're like, woohoo, look, we're #1 for this one. Kind of like the Dashi Awards. But also to collaborate and share best practices. Oh, look who's doing really well with this particular thing. Let's learn from them. We use it heavily for contracting. So not all of our payer contracts are through the CHA, but many are. And so when we have all this data, they're really able to advocate for, look at what this group of pediatricians in Portland is doing and how they compare to the state and what they're doing well, and why you should be paying them a little extra budget dust. We use it for reporting to payers, because they're all different reports and different measures, and so the data is all there already to go. We use it for medical home. The CHA, we support each other with a lot of medical home education and support and tools, and they're able to run reports for us, so I don't even have to do anything. It's all just printed out from all the data that's gone in. And we're also able to integrate and get data from organizations that we probably wouldn't be able to otherwise. So for example, our local Medicaid CCO does send some data to this tool through the CHA, and so we can retrieve that. It's also connected to EDDI, which is in Oregon and Washington, every hospital is signed up, and so when a patient shows up in the ER, it sends something. So even if we didn't get any information from the patient or a fax from the hospital when they were admitted or went to the emergency room, we can see that. We log on to this tool and we immediately know who was in the emergency room, so we can reach out to them immediately. It's so useful.
Is there more? That's already a lot.
A list.
So how, you have a list. That makes perfect sense. Is there anything you missed?
This is part the tool, but also part of the work that the CHA does on our behalf. They have done a ton of work advocating with our state on here's what's important in pediatrics. Here's data. Claims-based data is all just crap. Here's the actual data. Here's why you should be paying better. You need to correct your claims data. Here's what you should be tracking. Here's what you should be asking of pediatricians. And that's a big push, but they have actually made some changes in what was being required of us.
That's amazing. So, what would your advice be to someone who's maybe not in Oregon, but interested in population health data and what you can do with it? Do you have any advice for who to reach out to or who to talk to, what to do with this?
Yeah. It's interesting because it's very similar to all the things we hear from PCC and we learn at these conferences. But it's fascinating that other practices don't have a lot of these abilities, and they're not getting that message necessarily. So what's hard is a lot of these things we could do on our own through PCC. Maybe not everything, but I also know, like, for a lot of things, PCC would find a workaround for us, right? But I think it's very helpful when you are collaborating as part of a larger group, especially if not everybody is on PCC. It's been just invaluable. So I'm always happy to talk to people if they're interested in it and how we work together. It was interesting. We had a couple months ago at our Oregon Pediatric Society conference, we had representatives from all but one PCC practice in Oregon, and we met together, and I was like, man, we need to have something like this where even those of you outside of the CHA, we can just all like pool our data together and share our reports and stuff.
How do you think that membership in the CHA has benefited both your practice and your patients? You've mentioned a couple benefits like payer negotiations, but are there other things that you've seen improve?
I really feel like, it's just so hard to, and getting harder to be an independent pediatric office, but it's also just so important for our patients and for us. But I don't know that as a small group that we would have survived without the support from the CHA, just the collaboration with each other. I don't have to spend any moment in time thinking about I need to upload these reports to the CCO. Like, it's all being done for me, which is fantastic. I think it's been good for our patients. It's led to a lot of advocacy that we do through the CHA and together. People do listen to us in the state because we're over 140 pediatricians. I can't remember how many kids, like 150 plus thousand children. And so it does help us to be stronger together and advocate for kids. We've made some changes in the state.
Can you describe what some of those changes were?
So some of it has been the metrics, some of it has been just reminding them that kids matter and need to be part of budgeting. We went and, this was a few years ago, our state Medicaid would not allow parents and children to be on a separate CCO plan. And then they had to, which apparently we're going to head to again, they had to re-enroll every 6 months. And so we went down and we explained why it's really important, why continuity is important, and we had data as a large group of, look, when we worked on asthma as a group, our patients, look at how their emergency room visits dropped dramatically. Continuity matters. We take good care of kids. They need to be on the plan where they can see their pediatrician. And it was great. One of the CCO lobbyists got up to testify after us, and he's like, sometimes a patient's trusted relationship is with their insurance company. It was great. Anyway, so they changed the law so that kids could have more continuity with their doctor because we had the power and the data to show it.
So just to fill out some of the technical picture of this, the population health management tool, it's Innovacer, right? So I think that would be considered an HIE, a health information exchange. You have probably heard that term. Not all partners are going to be as valuable as CHA and the tool that they've chosen, but in your state, you may still have access to a relationship with a health information exchange and incentives to help kind of balance, the workload, say, of joining that partnership. PCC has a lot of health information exchange partnerships. As Scott Kirby would say, they're all managed in a project way, so it tends to be not something just a switch we flip, but we work with you and the vendor. We figure out what each party needs, what that connection needs to look like. We set it up custom for you, and we monitor it on an ongoing basis. And the Innovacer connection, I believe we're sending clinical documents. So if you've ever gone and generated a summary of care in the direct secure messaging tool and sent it off to someone else, that's the kind of information that we're sending to them, where they then pull out problems, diagnoses, vaccines, anything that they would need to see. And I'm sure you can fill that out more.
Screening results, orders, some of it goes through automatically, like that day. Some of it is set up in a monthly report, but it's really easy if we're like, okay, we're doing something new. All right, I just have to create an order, I add it to this report, and we're done. And I see the other practices like, well, we've got to call our IT people, and we'll have this going in 5 to 7 months.
So just to play, I'll take questions in just a moment. Just to play the math game, do you have a guess as to how many hours you've saved? Having an automated connection?
Unlimited.
Okay. We have
I
52
can't
hours a
even
year with Kim
guess.
over here. Unlimited.
I don't know.
You think about
So-
it. You could
so
put it in
many.
the app after. I'd love to take some questions. Lori?
It depends. So the question is, if PCC already has a connection with Innovacer, is that something that a practice needs to spin up a whole new interoperability request for? The answer is it depends. So, for example, if you're trying to join CHA, that's a much easier time for PCC. It's not even a deal of if it's easier. You can think of companies. We like to drop a lot of names. Innovacer's a really good example where they're a third party that works with many, many, many other partners. So they're the partner with CHA to deliver that clinical data to them and to format it into the correct structure. So if Innovacer is being used for a different HIE, it's a completely different project on their end. So usually we can't, if it's in two different states or two different areas, we can't leverage that existing connection in the way that you'd expect. So.
But all the PCC clients who are in the CIN can come together and create one interoperability request, correct?
Yes. So if you're all in the same area, this relates to almost everything we do, both like labs and HIEs are great, CINs. If you're in one area and there's a significant project that needs to get done, and you have multiple practices that are all interested in participating in it, that is approaching PCC as one kind of group is the most effective way. There's actually 2 examples of this recently on my plate for lab connections, where we had just one practice that was interested in the lab connection. And this is what we usually get back from laboratories. They say, oh, I don't know. We only make, over $1 million a year, but $5,000 to connect to PCC sounds like quite a lot. So we charge lab. This is total tangent, but I'll explain. We charge labs so that we can guarantee that they are going to finish the connection and get connected with your practice. So I recently had two different laboratories that did not want to budge on interacting with us at all until we had a second practice that was interested from the same area, and now suddenly things are rolling very quickly with them. So yes, the more PCC practices that are interested and that you can kind of organize around, the easier it is for us to speed up a project and make it happen for you.
And just to add to that, and then I'll take your question, that is because of what Brian mentioned. It is easier to motivate the partner to build that connection. So PCC is always happy to try. We'll reach out. We'll do our best just on a one practice basis. But it's really about getting that partner to answer our emails or commit to paying the fee. What was your question?
So currently for retrieving hospitalizations and errors, it's a lot of work for us. I have to, every 3 months I have to upload a patient panel to this CRISP system for Maryland, and then like every day or two I go and I pull reports of who's been hospitalized and getting the, who's been in the ER for mental health is even harder. I know that there are two-way connections available, but my understanding last time I talked to Chris was that, they're going to be able to pull out of our system if we're getting stuff pushed to us from their system. And, that years ago when I looked at this, I think patients do have the right to refuse to have their data. There used to be some checkbox that we can check off and partner or something, or EHR if parents don't want that. Is there still that checkbox there?
Yeah, so I'll repeat the question. I think, so broadly speaking, what I'm hearing you say is that you have a state system where you can retrieve information about hospitalizations, but it's a hassle to sign in and then pull that data into PCC, and you're wondering if there's the option to do a bidirectional connection where they could both pull information out of your PCC system and also maybe give you information about hospitalizations without you having to log into a portal. And then there was a second part of the question relating to consent, family and patient consent for information sharing. I'll speak to the second part first because I actually know the answer to that, although I think Brian will be able to shed light on the former. There is absolutely a way to record patient consent. We take that very seriously. If you've ever talked to anyone on our team, mostly Romney, I think, is the person who'll guide you through that process in the white linen shirt back there. But we have the ability to set every patient to no, and you can only opt patients in from there. We have the ability to set every patient to yes, and then you can opt patients out from that point. Like, there are really a lot of ways we can do it. And we can use that field in different settings. So yeah, that's absolutely an option.
Yeah, I don't have too much to add, but there are multiple opportunities that we could probably work with you and for your practice and with the state system that you have. So we'll have some information up on the screen for doing an interoperability request. Yes, generally there are exactly what you're talking about. There are ways to streamline that process, but wide varying answer.
Alex, did we have any questions from online? Nope. All right, so Dr. Matthew, just to throw it back to you for one last thing. You already kind of gave some advice, but like, if you could just highlight like your favorite thing about having put in place this connection, what's the number one thing you would say is your favorite aspect?
Oh my gosh, it's like choosing my favorite kid. I just love seeing charts and tables and data and comparing. I don't know. It just scratches something in my brain. I love it. So we get these beautiful quarterly reports with how we're doing on all of these different measures and broken down to like by physician in your practice and like who's doing what better. And it's great. And it's just such an easy, digestible way to give the information to our staff or to work on it. It's just so easy.
Thank you so much.
Thank
Give
you.
a hand for Dr. Matthew,
Yeah.
please.
We'll move on to Kim. Kim started explaining all of the complex things that you were doing before we started talking last year. Can you go through that again for me and explain exactly what your process was for, because you're doing lead result reporting to the state of Ohio,
Yes.
right?
So every Monday I would run a report because we have to, in Ohio, you have to report within 7 days the lead results. So ran the report, and then I would have to type into the lead care system the name, the date of birth, their Medicaid number if they had Medicaid, their address, their phone number, the parent's name, the result, the blah blah, yeah, just on and on and on. And so I would type all that in, and then I had to do it per location. So we had 2 locations. So you start the file, you type it all in, then you upload it to the FileZilla, which I guess is the thing that transfers the file to Ohio. I'm not smart in this sort of thing, but anyway. So then you send it off through FileZilla. Then I would go back, do the second office, and do all of that again. So depending on how many results there were, it could take up to an hour. But now I run the same report. But now it just all magically goes. I get an email every day, I guess from Brian or from the system, whatever, that tells me what the PCC number, what the result was, and that went that day. And then I just double check with the report that all the results went. Only one of them didn't go. I don't know why it didn't go, and it was only one, and I was going to wait. I didn't tell Brian because I'm like, I'll just see if more don't go. But then only one never went. So I just did it manually. But we also report to Indiana and Kentucky, so I still have to do those. But there's not as many results for Indiana and Kentucky because we have mostly Ohio patients. But yeah.
Yeah.
Brian's
It is.
not writing an email.
No, I'm not writing an email every day. I did tell Kim last night that I would change the signature so that it says my name on it if it makes her feel better. So I'm curious from your perspective. So you found out that this was potentially an option.
It was just a word on a slide in a thing.
Yeah.
It said lead reporting. And I was like, well, if I can do that, I want to do that because this way the process is not dependent on me. I can be in the office, out of the office. The results still go. So I was like, let's see if it's possible.
Yeah, and then what was from your perspective, what was the onboarding process like? So like you reached out to us. I still remember your email, which was, I think it was one sentence, and it said, "Hi, I heard that lead reporting might be possible, and I am really, really struggling with reporting lead results every single week," or something to that effect.
Can you help me?
Can you please help me? Yes. What was the process like from that point
So I
forward?
think after that, you emailed me back. You're like, yeah, let me look into this. I gave you the state contact. I think I gave you all the data points that we had to upload and or include in our results. And then you contacted the state, and then you did all your magic on the other end. And then it just worked. Now, I will say, when we first did it, the results were going in real time. So we had a couple issues where the hemoglobin results got entered into the system as the lead result. So a couple parents got letters saying, your child's lead level is 11. And they're like, what? What is this? Why am I getting a letter from the state of Ohio? What is going on? And I was like, I don't know. Let me look at it. And I'm like, well, it says in here that your lead was less than 3.3. So I don't know why you got this letter. So it happened, I think, twice. And then I emailed Brian and I said, can you see what happened? Because I can't figure it out because it says that the lead level is normal. So he went back, and one of them was the MA entered it incorrectly and then corrected it later in the shift. And then the other one was the MA entered it incorrectly, and the doctor corrected it, I guess, when she was finishing her charting. So I was like, oh, I said, well, can we make these not be immediate then so that we don't get these letters, or parents aren't getting these letters? So now they go once a day after the office closes, and I haven't had any issues since we did that.
Yeah. Just a subtle reminder that if you ever think something is really weird in your system, we can see everything that you've done.
In a helpful way.
In a helpful way. We don't do it to make fun of. So Kim, I think I had a little bit of a panic attack when I got that email from Kim about these letters that went out to parents. One of the interesting things that we noticed with most states have some sort of automated lead reporting process. We are connected with maybe, I think, 10 different states at this point. It's really kind of this weird dungeon-like secret organization set up where there's one person in the state's health department that's ever heard that they can even do this. So PCC has to really knock on the door quite a lot to get it running. And to that end, they also don't really know how it works, other than that it does if you send them the right data. So that's what we see in most states, and Ohio is no different. Sarah has a question. I can pull one up for you. We'd want you to fill out an interoperability request form. So we'll have the link up to that on the screen in just a few minutes. I think, what state is your practice in? New Jersey. I think we may already have at least one practice that's able to do it. So we can look into that for you.
I have a question for Brian. Can a practice do multiple lead connections? So Kim is saying that she has 3 states that she's doing reporting to. Can you set that up for her?
Yes, it depends on the Department of Health in each respective state. If they're, they might have weird arbitrary rules about not accepting lead results electronically from a different state or something like that. But in Kim's case, Kim needs to report lead results to 3 different states, 2 of them very infrequently, but both of the other states are on board with allowing their practice to do that, which is awesome. Yeah, do you have anything else to add about?
No, we've sent 452 results since December, and like I said, only one of them didn't go through, and then we had those couple minor issues in the beginning, but the process was very, very simple, and if you can get it set up, I would absolutely do it because it's a time saver, and it's not dependent on one person doing it anymore, so.
Awesome.
So I think at this point we can go to general Q&A. We've got about, a little under 15 minutes left. Let's actually put our hands together for Kim before we move on. She shared with us that her introversion was telling her not to do it, and she came up here anyway. So we appreciate you, Kim. You did awesome. Are there any other questions for our panelists or for Brian? And we actually do have a way to submit them at Slido if you'd like. If you're scared if you don't want to speak up. Lori, go ahead. So the question was whether or not we could talk about direct secure messaging. I don't know, presumably your practices have this set up, but would you like to speak to direct secure messaging? Here, I'll give you the mic.
We have had that happen a couple times in the past few years, and with a call placed to PCC and a call placed to, for us it's Children's National, someone figures out what the problem is and they fix it. So it's some coding issue or technical issue. What we get is we get a attachment that's a PDF, and then we actually, I don't know if we really have to do this, but we print the PDF to the EHR and then reattach. It would be nice if we didn't have to go through the stack and queue to do that and could just do it directly, but that's, I forgot about that until just now. It shouldn't be like that. That's some kind of error. But not all the hospitals have it. Like, Hopkins doesn't seem to be able to do this for us, and MedStar doesn't, but Children's National does, so it's worth us having it.
Thank you. Are there any other questions?
Yeah, I think that's the biggest lesson for sure is reach out to support anytime. If you see anything weird or that doesn't seem like it's working properly or is just unreasonably hard, please reach out and we will do our best to correct any sort of interoperability woes.
So the question was, what other things besides lead reporting can we do?
A lot. Are you interested specifically in reporting or? Oh boy. Let's see. So so our team is specifically like we have a few different realms that we operate in. We do, I mean, any sort of reporting that you might need to do to the state or to any other organization, we can generally do. So the most common one on top of my mind outside of, and yeah, so you can actually see the interoperability form. We might actually, I don't think there's a drop down there that shows all of the options in this screenshot, but there is a list, and it is very long, and sometimes I don't even know what to select when I'm helping somebody with it. The most common reporting interface other than lead reporting is COVID reporting, which is still common in certain states. We're in charge of all of the electronic lab connections, so I think we're integrated with over 100 different laboratories across the country now. What else do we do? We do bi-directional and one-directional vaccine messaging. So this is vaccine submissions and history.
Right. We have care quality connection. So essentially, we have implemented the care quality framework, and actually, that's used for direct secure. No, that's used for clinical document exchange. So we have a method by which you can opt in to share your clinical documents with other members of this network. So they can just pull them from your system, and you can also pull clinical documents from their system. So say your patient sees a specialist somewhere and they're a member of this network. You can query the network and pull the notes from their last visit, say, or the clinical document from their last visit. Yep. So the question was, can you query them from within PCC? You can. It's essentially an anchor button in the chart that gets exposed once you go live with it. And just like with prescribing controlled substances, one person in your practice will have to go through identity proofing to get set up with it, but that's really the biggest hurdle. And then there's there's a little bit of contracting as well, just data sharing agreements essentially.
Yeah, you can.
So that's a very popular request connecting to the prescription drug monitoring program in your state. Much like immunization registries, that is a state-by-state connection. So it is on our roadmap to start building those. The question is, will we take a one vendor approach that connects to all of these different places, but not 100% of them, or more of a one-to-one approach? So once we get past the electronic prior authorization project for prescriptions, our next big project on the roadmap is those PDMP integrations. So you're not alone, Lori. It's a very popular request. It's on the roadmap. It's a few years out, but it's there.
I think we may have one. I do know that there are several states. Awesome. In Texas? Michigan. That makes sense. I was going to say. Well, so the question. Go ahead. Well, yeah. The original question was, do we have any integrations for reporting newborn screenings? And we do have one active one in Michigan. Does it work well? And the participant says, yes, it works well, and it's amazing. That's awesome. And I promise I'm not lying to you about what they said. I do know we have a few states where clients have approached us about, their state theoretically accepts them electronically. We have had pretty horrific luck with getting any Department of Health to really move on integrating with us for those. Romney, are you aware of any other states that accept them right now? Yeah. Any other questions? Or any other questions for our awesome panelists? we can talk quickly about the interoperability request form. This is the most exciting form you'll see today. So if you go to pcc.com, please take a picture of this. I think we'll leave this up at the end of the presentation. If you go to pcc.com/interoperability/request, we have this beautiful password protected form. It's password protected because people, when we don't have passwords on it, really like to find it and send us a lot of random text. It'll help us kind of gather the required information that we need to investigate a potential interoperability project for you, and get back to you as quickly as possible with what we can do and what it's going to take.
And you're always welcome to email support@pcc.com. I will say that is like a general inbox, and so the person who gets your email initially may not have all the knowledge required, or may not know all the questions to ask to gather information about your request. So that's why we have this form, because it just kind of cuts right to the chase and it tries to get all the information up front, so that you're not going through a general inbox and someone where it's not their area of expertise. Although if you email that person, they will definitely get you to us. It might just be like a couple more steps for you. So that's why we have this up. And we do have a list on pcc.com of all the globally available connections. We keep that updated as well as possible. And you're welcome to reference that and reach out about that. And those are what we call included connections. So we've already built them, they're established, and there's definitely no fee for those. For some of these and we generally try to structure a fee so that it's the vendor, the third party, who's paying that fee. But it's sort of assessed on a case-by-case basis. So please do not let the worry about a cost prevent you from reaching out to us. We try very, very hard not to charge our practices to get these connections built. So let's have one more round of applause for our panelists. Thank you so much. Go ask them questions. They're really awesome humans, and I hope you have a great rest of the conference. Thanks, guys.